now we are going to move on to the next panel discussion about the difficult endometrium. This is going to be a very well-presented case-based discussion, and we are having a galaxy of panelists for this. So the first panelist is Dr. Jyoti Agarwal, who is a Senior Consultant and Director of Life Care Center and Life Care IVF, which is situated in Kolkata. Then we have Dr. Poonam Goyal. We have Dr. Poonam Goyal, who is a Senior IVF Specialist, also from East Delhi. Then Dr. Jyoti Malik, who is a Senior IVF Specialist from Roots IVF Center, Bahadurgarh. Dr. Aruna Saxena, who's from Ghaziabad and a very senior IVF specialist. Dr. Sunita Arora from Bloom IVF, South Delhi. And so let's start the discussion. I hand over for moderation to Dr. Seema Sehgal from IMB IVF Center and Dr. Megha Malik Aneja. Thank you.
So after listening to Dr. Jyoti's talk, I think beside the thin endometrium, there are other probabilities, other difficulties are there. Sometimes there's a blood inside the cavity, sometimes there's a fluid inside the cavity. So we are here to discuss and listen from all the experts and panelists and discuss the problems, and we need answers for that. So I'm handing over to Dr. Megha Malik. Dr. Megha is IVF in charge in It's My Baby IVF Center, and she's the lead infertility specialist in this area. Welcome, Dr. Megha. And
thank you, ma'am. Thank you for the lovely introduction. So I welcome all my panelists. I'm going to start with the first case. So the case is 38 years old female. She's secondary infertility, previous cesarean. She has a daughter of 10 years. She took the antitubercular treatment for 6 months because TB from 3 years back. After starting her HRT protocol for the embryo transfer, we made good embryos. And then we started on with the HRT protocol for the embryo transfer, but she had irregular withdrawal bleeding.
Dr. Aruna, please, can you mute your mic, please? Because it is, yes.
So we started with the HRT protocol. She had irregular withdrawal bleeding. We gave a down-regulated cycle. Again, she had irregular withdrawal bleeding in between. And in ultrasounds, it was intrauterine bleeding, we found out. Same Letros-induced cycle also, she has the same complaint. Hysteroscopy was done, the clots inside the cavity, they were removed. Again, she had that bleeding in the next very cycle. Again, we did the hysteroscopy. 2 months later, similar dark colored clots were seen inside the cavity. We removed it, the curating was done. On histopathology, it was found out that there were small polypoidal tissues, and basically the report was saying endometrial polyp only. So question is how to prepare her next for the endometrial transfer. We have not given her transfer once. Every time she has this dark colored bleeding, intrauterine bleeding that is coming from the endometrium and the upper part of the cavity. So to our panelists, one by one, Dr. Poonam Goyal. Ma'am, your comments.
I think in this particular patient, we had polyp. So in this patient, right now also you are facing the problem of blood every time. So we can just do one mock cycle with high dose of estrogens and then see how the patient behaves, how the patient goes. If we get fine endometrium, then okay. If we don't get fine endometrium, then we may have to do one more hysteroscopy and then start.
High dose means up to like
high dose, like we will start with 1 tablet TDS and may go up to 4 tablets a day.
So, Dr. Sunita,
but considering that we thought it is an excess of secretory activity or excess of proliferation, so we were dealing with both of the things. Once we have done a suppressed cycle, I think we need Dr. Sharma's input on this.
See, we should look into the histopathology of this endometrium.
So we have done that.
Mild lymphocytic infiltration.
Yes, sir.
Why the lymphocytes should be there in the endometrium?
Yes.
So the lymphocyte means that there is a chronic inflammation or infection which is going on. Though she has taken ATT earlier also, I think this patient may still be harboring some resistant tubercle bacilli. We should try to do the PCR again and maybe AFB again for this patient. Because lymphocytic infiltration is an evidence of chronic inflammation. So tuberculosis should again be, resistant tuberculosis there or not, we should exclude that.
So should we do the rifampicin resistance and MDR tuberculosis type things?
Yeah, because in case it comes positive, then we may have to give this MDR treatment to this patient.
Dr. Jyoti Bali, can you comment, sir?
Ma'am, I would agree with sir, but here, after having ruled out resistant tuberculosis, maybe some other overlapping infection, give her proper doxymetro course, and after having ruled out resistant tuberculosis, what Dr. Brig RK Sharma and Poonam Goyal ma'am said, give her a course of complete antibiotic. I would give her high dose progesterone for 1 or 2 cycles and then start her preparation. This uterus, this cavity must heal from everything, and then the estrogen part can be taken up. Because polypoidal cavity or a lot of polyps there, I think she needs a break with progesterones.
Sunita, Aruna ma'am, and any other comments? Sir wants to say something.
Yeah. So basically, sir, पहले आप बोलिए sir, please. Dr. Sharma sir,
Yeah. Now, what I feel is that yes, to detect for the MDR is going to be difficult in this case. What Dr. Jyoti has said, we can give her doxycycline and tinazole and maybe antiviral also along with that, and then repeat the endometrial biopsy after the luteal phase of the next cycle, and see if the lymphocytes are still persisting or not. If they're still persisting, then we should try to make an effort to exclude the MDR.
So I would like to add that, so many times all of us have seen patients where recurrent fluid comes in the endometrial cavity. So there are 2-3 things which I always follow in these patients. I have seen in quite a number of cases that, this history that patient is missing estrogen doses in between, because some patients are so prone to fluctuating level of hormones that, missing a dose makes them bleed inside. This is one. So in next cycle, make sure, in that particular cycle, you can increase the dose of estrogen and then observe the patient if patient is in early part of cycle. But if patient is in later part of cycle, then obviously any fluid inside the cavity, I usually cancel the cycle. I never do that, aspirate the fluid and then try doing embryo transfer. I don't follow this because I don't think we get results in such cases then. That is one. And second is we should also look at the absorption of estrogen, because sometimes if there is some absorption defects in the gut, then changing the route of estrogen maybe to a transdermal may start building her a better lining with no fluid in the cavity. And third is for sure these kind of patients should be given a proper course of doxycycline and metrogyl. And yes, of course, regarding tuberculosis, as Dr. Sharma sir has said, that we have to rule out that recurrence of tuberculosis is happening or why these lymphocytes are there. That has to be looked into.
We've given her doxymetro course.
Thank you very much.
And also she, in the letrocycle also, when she was taking the letrocycle, the bleeding was in the later half, after 10 days. Earlier with estrogen, it was initial after 4-5 days of estrogen only. But in the letrocycle, there was bleeding, but it was after 10 to 12 days of the start of the letros stimulation.
Dr. Megha, did you try natural cycle in this patient?
Yeah, we just give letros, not
just a simple natural cycle. Maybe if nothing works, yeah. And I agree with Dr. Jyoti Bali. She should be given a 3 months course of progesterone, and then she can be tried for natural cycle.
Thank you.
Thank you.
I agree with Dr. Sunita Arora. I have seen patients, they miss the afternoon tablet. 2 days she will miss and then she will bleed. So in 2-3 patients, I had to do 2 BD. You take 2 BD if you can't take afternoon tablets.
True.
Yes, sir. Sir wants to say something.
Yeah. See, this multiple, the polypoidal tissue, what they have written, it is a histopathological diagnosis. It was not seen in the hysteroscopy. Many times the chronic infections, they will show you on histopathology, the polypoidal tissue. While when you are looking at the hysteroscope, you may find it's a normal, because the hysteroscopic cavity has been, except for the clot, was normal. There was no polyp as such in that. It is only the histopathological diagnosis. So again, it is pointing us for some chronic infection, whether it is tuberculosis or it is viral or whatever chlamydia, we have to exclude that, and then possibly after treating them again repeat the histopathology and confirm that lymphocytes is not there and it is no more polypoidal, and then possibly your response to stimulation will all be better in this case.
Thank you so much, sir. Thank you. I think Dr. Jyoti Malik is here. And Dr. Jyoti Agarwal, ma'am, your inputs?
Yeah, I agree with my previous speakers, and I will also do the same thing. I will stop all the medicine. Maybe I will try to do a mock cycle for her, and if that is okay, in between I will give her acyclovir. Tuberculosis she has already taken, so there is no point giving her again and again. But yes, I do believe the concept of viral endometritis is coming up, and I have started giving acyclovir to my patients also, and then we downregulate and then start her on HRT cycle. This is what I will do in this case.
Wonderful, wonderful
Yes.
panel. I think I must summarize. One is we have to give doxy, metro, and that too for 3 weeks. Secondly, we can suppress the cycles for 3 months by progesterone. Fourth is we should see whether she's taking the medicine properly or not. And fifth is we can try a natural cycle. And sixth is acyclovir treatment. And lastly, as Dr. Jyoti Bali has suggested in her slides, that amoxicillin can be tried.
MDR-TB also.
So this is the first question. Now moving on
The
to
MDR-TB
second.
should be ruled out. Yeah. Thank you so much. Thank you so much. Next question. So a second case. On the slide.
Okay, second. Yes.
So we move on to a second case. She is a 32 years old female. She had a first ectopic pregnancy, and so salpingectomy of one side was done. Then it turned out to be TB PCR positive, and she took the ATT for 6 months. She had 2 subserosal fibroids, very small, 1/2 mm in size in the posterior wall and one in the fundus, which were not significant. On hysteroscopy, there was a polyp which was removed, and she was started on HRT cycle. So up to like 4 milligram and 6 milligram endometrium was the estrogen was given. Endometrium is to prepare early on day 9 or day 10. It was ready beyond 13 mm in fact, and she had 2 implantation failures on such endometrium. So my question is, what next for endometrial preparation in such patients where endometrium gets ready in the early stage? Yes, ma'am.
I think, Doctor, what Jyoti Bali has just explained, the down-regulated cycle will be better in this particular patient, starting from the low-dose estrogen and then stepping up the estrogen dose.
Yes, ma'am, right. But we have done one cycle down-regulated cycle. It was the same. Endometrium used to get prepared early. So we transferred the embryos. They were good quality embryos, but the result was negative. Any Dr. Jyoti Bali wants to say something? Yes, ma'am?
Did you use a depot preparation?
Yes, ma'am, depot preparation. We use depot preparation only.
And the dose should have been, to pull it up 4 milligrams से भी less dose पे start कर सकते थे. OD पे start करके then BD and then TDS पे.
Okay, ma'am. Right.
Step up dose of estrogen after down regulation.
More physiological stepping up.
Right, ma'am.
Dr. Megha, I have experience of 2 such cases. The endometrium was getting ready very early and very hyperplastic kind of. I put Perena for 6 months, followed by natural cycle. It worked very well.
Okay, ma'am. Merina. Yeah. Yes, Sharma sir, any comments?
Yeah, I would like to know her, blood flow in the pelvis. Because some ladies, they have a very prominent blood vessels. The pelvic congestion is very high because of infections. So if the congestion was very high, the blood supply will be more. So even the less dose goes to the endometrium. So endometrium gets prepared early than expected, and it becomes very thick. So if there's excessive pelvic congestion, exclude any infection and treat it. And otherwise, as suggested earlier, maybe you downregulate this patient and start with the very low dose, the estrogen, and step up slowly so that, the patient doesn't form the endometrium very fast also. Because what happens when the endometrium grows very fast, the ratio of the glands and the stoma gets affected. So with the result, the implantation is poor in these patients. So it should take at least 10 to 12 days or more than that to prepare the endometrium. If it is getting, ready, say on 8th day only, the endometrium is 9 millimeter or 10 millimeter. So it looks very, tempting. Okay, I can transfer the embryo, but definitely the result will not be there because the histopathology of the endometrium gets affected by, the fast growth of the endometrium. Because the stoma will grow fast, the glands will not grow faster. So that problem occurs. So if you see the histopathology of these patients also, that will also give you a clue. So my suggestion is look for any excessive pelvic congestion in this patient. And if you find that, then especially if there is also probe tenderness or please give her antibiotics. And secondly, downregulate and then give a low dose estrogens to prepare the endometrium.
So any role of ERA, doing ERA?
See, I do not really believe in ERA because ERA is this, what I feel is it is a cycle specific. Because I get a lot of patients, who have been advised surrogacy and they could not afford it based upon the ERA that your ERA is not good and you cannot conceive. And they had twins also in the first cycle only. So ERA, well, I wouldn't totally condemn it. Possibly we have not understood it as yet, or maybe what in India we are doing is may not be doing rightly. So with the result, it does not really correlate well with your clinical practice. This is what I have felt in my own thing. Also, I get a lot of patients who have been advised for poor patients.
Can I say something?
Sure, madam.
Yes, ma'am. Yes, ma'am.
So, Sharma sir, basically, I feel this particular case, although as you said, you're not very fond of ERA, same with me also, because we feel it is cycle specific. But because as Dr. Megha and Dr. Seema, they have pointed out that this girl is having this similar history for past 2 cycles. She is making very fast endometrium and she soon. So I think this is a case, if we are sure that we are having good embryos, which we actually can never be sure, even morphologically very good looking embryos may be genetically abnormal. So we have to look at both the aspects. We have to look at, are we dealing with normal healthy embryos? So we can think of genetic analysis on embryos. But because, today's seminar, we are focusing on endometrium. I think this is one patient where we can think of ERA because she is responding almost similarly in all cycles. And we have to see whether at receptor level, she is doing fine or not.
Yeah.
So we can do ERA, these kind of patients. This is what I feel.
Because we have one similar patient in past, and that patient, we did ERA, and according to ERA, we have stretched the cycle beyond 12th day, and we got the result in first cycle. Though she had IVF cycle at some other place, and that time also embryos were excellent, endometrium was excellent, and still she was not getting the result. But with the help of ERA, we were able to get the positive result in first cycle only. So we also believe in that. And thank you very much, sir. Thank you, Dr. Sunita.
Jyoti Agarwal, ma'am. Your inputs?
Yeah. I'm not doing ERA, and I don't believe much in ERA because it increases the cost of the cycle also. Besides giving the success, you have to do 2 similar cycles with everything same to same. It's just a photocopy of one cycle. I would downregulate this patient and then step up very gradually over a period of 3-4 days, gradually increase so that we at least have 12-14 days before the endometrium reaches 8 millimeter. This is what I would like to do in this case. Downregulate as the message of Dr. Jyoti Bali for today's webinar.
I would like to, regarding past question, what is the general experience about ERA of all people? I have never done ERA.
I have never done.
We have done, ma'am, and where we have got results accordingly. If there is any deranged report in the ERA, we have got good results.
Means at times it is better to...
In repeated failure cases, it is helpful.
Then we should not see the cost in repeated failure cases.
Can I add something here?
Yes, ma'am. Yes, ma'am.
There are so many preparations coming in the market with estrogen and with the depot preparations. Off late for last 4 months when I faced difficulty in, getting all linings getting cancelled in the...
Dr. Jyoti, आवाज कम आती है आपकी.
मैम इतनी तेज आवाज है, लोग तंग आ जाते हैं और आप कहते हो कम आती है. अब तो चलो, anyways. Ma'am, am I audible now?
Yes, yes.
Okay. there was a time when I just off-rate in the clinic, we found that, our cycles were not coming up well with all our frozen embryo transfer cycles. We really were frustrated as to what to do. Change the preparation of Depo. I wouldn't name any company here. I changed the brand for my, the estrogen. All of a sudden, the results are back. So sometimes these preparations also need to be looked into as to how we are maintaining, from which stockists they are coming. Sometimes I wouldn't name any brand here on this platform, but there has been a problem even with down regulation. How many of us with down regulation have checked the E2 levels after having given a Depo preparation? I have never done it.
Not in it. Yes.
Yeah. So either it's the Depo preparation with the down regulation was not proper, or your estrogen preparation, which has not given you complete control. So I did find, and I changed the brands in my clinic, and now the cycles are very fine. This was the first time I had this experience in 12 years. Never faced this before.
In few patients, we have done the day 2 hormones, and they were really not suppressed. You're right, ma'am.
Yes. So look after the brand that you're ordering for your suppression.
Have you found any difference in Depo and then daily injection? Because what I have done down-regulated cycles, that I have done daily dose, never with Depo.
Daily dose is actually a very, when we were practicing around 10 years ago, when we were on long protocols for a lot of patients and only few antagonist protocols, I found that it was too long a protocol to carry, and then non-compliance, then pricking every day. I don't think it's in good taste with the patient. Make it as comfortable as possible. This, I think, after having given these Depo preparation, I've forgotten how to use those daily ones. I've never ordered also. That 4 ml vial that used to come, I've never ordered. 0.1, maybe 10 years, 12 years ago when I started, I was giving it, not now.
Thank you so much, ma'am. Thank you, everyone. So we move on to our next case, third case. She's a 37 years old primary infertility case, has a history of azoospermia in the male partner. On laparohysteroscopy 3 years back, bilateral beaded tubes were seen, but there was bilateral spill. So she also took the TB treatment for 6 months because of the PCR positive. Now for frozen embryo transfer, repeatedly we found fluid in the cavity. No hydrosalpinx was seen on ultrasounds. ET was good around 8 to 9 mm triple lined. Fluid was drained and embryo transferred, but the result was negative. So what next? Question, Sunita Arora, ma'am.
I think we have already discussed this. My first take would be to give doximetro first and then try another cycle. There is a possibility of infection in this particular patient.
She has taken, because it took a lot of months to prepare the lining. She has taken doximetro course. Even the ultrasound was done from outside. There was no hydrosalpinx seen. So my question is, should we do hysteroscopy and occlude the ostia during the hysteroscopy by the roller gauge? Any experience of our panelists on that? Or clipping?
But if there is no hydrosalpinx, then what is the
question, Megha? Can you repeat your question?
If there is no hydrosalpinx.
Ma'am, should we do the hysteroscopy and occlude the ostia? I agree that there was no fluid seen in the tubes by ultrasound, even by us, even the outside ultrasounds. So we drained the fluid, we transferred the embryos, result was negative. Repeatedly, fluid comes in the cavity after preparation. Lining is good, but then again, fluid usually comes in the cavity. We find a fluid inside the cavity. So question is, should we do hysteroscopy and occlude the ostia through the hysteroscopy? Or we do lapro again and do the clipping? Your experience?
Yeah, so see, basically hysteroscopy for sure. We have to do a hysteroscopy because sometimes we may see lining is 8, 9 mm, but then when you do such, take up such patients for hysteroscopy, you do find some adhesions because even 3D ultrasound not 100% sure. Hysteroscopy is a must to rule out any other, factor. Then coming to whether we should clip these tubes. So see, rule of thumb is if you see a hydrosalpinx on ultrasound, then you definitely have to clip. But sometimes you have to individualize the cases, and on your practical experience, yes, I feel if the tube is so diseased that will not help patient, getting pregnant natural, and there is no other cause inside the uterus. You've already given a course of doxycycline, metrogel, and you've ruled out tuberculosis, or your patient has already taken ATT. Then apart from ruling out tuberculosis, again, once in a while, I have seen that, after proper counseling, if you occlude these tubes, but I think Assure is not FDA approved now and it is out. So if at all, you have to do it laparoscopically. Clipping can be done, once we are sure that these tubes look so unhealthy that they are not capable of giving a natural pregnancy to the patient, I may do this after a proper counseling in this case.
Right, ma'am. Poonam Goyal,
I
ma'am.
think Dr. Sharma sir should give his opinion on this.
If we do that down regulated cycle and then give slow estrogens, I think that one cycle you can try before doing operative.
Yes, we have tried all that.
Of course, we have to try all that. We should try all that before we jump on to this conclusion.
These are the difficult cases. We have tried all
giving them some antivirals
Yes,
also. Try giving them some antiviral, maybe cyclovir for 7 days, and then down-regulate and then see. Because fluid in cavity means there is some kind of endometritis which is coming up.
In this COVID era, anything is possible, Dr. Jyoti. We don't know.
Absolutely right. Yes, absolutely.
Jyoti Bali ma'am, any comments from your side? Dr. Jyoti Bali ma'am?
Anji.
Any comments from your side?
No, I think I'll agree with all the speakers who said this, because this is my protocol also, because I do not like to clip tubes unless, as Dr. Sunita said, that there is, I would get a 3D scan before saying that. I would not rely on a 2D scan. 3D scan should be done, a proper reporting of that. If there is nothing, laparoscopy should be taken up in these cases. And if on laparoscopy, the consents have to be taken prior. In case you feel that this tube is a problem, then of course clipping can be taken.
This patient, we repeated the hysteroscopy, and there was an internal loss. It was very tight. We have done the dilatation as well as clipping of the tube done, and then the transfer was done, and patient got positive result. That was a thing.
Wow.
Thank you very much. Sharma sir is there?
So I think you did the right thing because with the fluid which is present, see what is happening. Hydrosalpinx sometimes may not be visible at the time when you are doing the ultrasonography, and in some patients I have found even the posture change and all the hydrosalpinx fluid gets drained into the uterine cavity. You do the ultrasound, you don't find anything, and no hydrosalpinx, but actually it is there. So I think it was the right thing you did, that you did the clipping for this patient, and that helped her, becoming pregnant. So I think it was the right choice, because when we do ultrasonography, it is a one-point ultrasonography. We do not know at other times when the tube was, filled or not. If you do in these patients, little more frequent times ultrasonography, you may be lucky to catch the hydrosalpinx. And if still it is not there, I think then maybe HSC would help you. Because if a big hydrosalpinx is there, which is not visible on ultrasonography, so it was a draining hydrosalpinx. So HSC will show you, yes, it is there. So then it will be becoming more easy for you to convince the patient for the clipping of the tubes.
Sir, thank you for the valuable comments. I would invite now Dr. Archana ma'am to say the vote of thanks.
Just before concluding, sir, I have one patient. She is coming to me, I think October se mere paas aa rahi hai. First complaint was she came with secondary amenorrhea. Okay, her thyroid report was normal, she already had. I did the scan, and when I did the scan, there was a recent evidence of follicular rupture, very early secretory endometrium, and very good triple line endometrium was there. So what I did, she was keen for conception also. So what I did, okay, go keep relation, and I started progesterone and called her after 16 days to see, and she came, she had no periods. I was almost 100% sure that she is pregnant, and when beta HCG was done, it was negative. I did the scan again secretory endometrium पड़ी हुई है वहाँ पे और वो bleed नहीं कर रही है. फिर मैंने उसका prolactin करवाया. I thought let me check, maybe her prolactin is high, prolactin level भी normal आ गया. Patient परेशान होगी, period हो नहीं रहा, क्या मुझे कुछ मिल नहीं रहा था. And I put her on OCPs and sent her back. And after OCP she has come again. अभी भी period नहीं आया. What could be the reason when there is good endometrium, hormones are normal, why she is not bleeding? मुझे तो नहीं समझ में आ रहा.
Hysteroscopy, that is a must.
Hysteroscopy.
Yes, ma'am, it is sometimes the adhesion which gives us false impression of secretory endometrium and thickness. And
first time when she came, follicular rupture, fluid was there, and crenated follicle was there. Hysteroscopy is the only answer.
What was the progesterone? Did you see the progesterone levels, madam, for this patient?
तो मैंने क्यों करना था? प्रोलेक्टेड मतलब मुझे मतलब पल्ले ही नहीं पड़ रहा, मतलब सब कुछ मुझे दिख रहा है, तो पीरियड आ गया.
Once you stop the progesterone, she is not getting period. You know, the patient will get period only when there is a withdrawal of hormones.
Yes, I stopped it and told her to wait for 20 days. She came back 20 days without periods. Then I started.
That's what I'm saying. In these type of patients where there is a doubt, you do the progesterone and you find that her estrogen progesterone is still very high.
Actually, the withdrawal has happened or not? That you mean to say?
Yeah. So just to confirm that the withdrawal has taken place or not.
Beta HCG levels?
हाँ, beta HCG क्या negative?
Hope she's not carrying an ectopic somewhere else. Some
कुछ नहीं.
other ectopic.
उसके बाद भी तो 1.5 महीना बीत गया ना, कुछ भी नहीं हुआ.
I think if nothing, if the progesterone levels are low, you just give her misoprostol, she will have menses. Or otherwise, you give her good ajwain. The old ladies used to, advise their daughter-in-laws. So normally, I tell my patients, such patients, the kada of ajwain, zira, and salt and good. So they get the periods. Otherwise, misoprostol to give the patient.
Thank you.
Thank you, sir. Thank you so much.
Thank you.
So, Archana ma'am, vote of thanks from your side.
Yeah. Thank you for such stimulating discussion. Yeah. Thank you, sir, for your inputs. Thank you, Sharda ma'am. Thank you, everyone, all the panelists, Dr. Poonam, Dr. Jyoti Bali, Dr. Sunita, and of course, Megha and Dr. Seema Sehgal for their excellent moderation. So thank you very much. Dr. Aruna, too. Yes.
All the delegates, please do join. Next month, we are again on 20th only. This time, we have just preponed because of the Sunday. But next time, we'll keep this in mind that 20th is Sunday is better than Saturday. Because Saturday is and this day is, I think, because of the heavy saya, everybody is in the marriage, some or other marriages. So thank you very much for joining and sparing your time, and look forward for further meetings. Thank you very much.
Thank you.
Thank you so much.
Thank you so much, Dr. Seema.
Thank you, sir. Thank you, Dr. Jyoti. Thank you, everyone. Have a nice day.
Thank you, sir. Thank you.
Good day. Jyoti Bali, definitely. Thank you very much.
Thank you so
All
much.
the best, everyone.
Thanks, Megha.
Thank you, ma'am.
Thank you so much, Sharma,
Thank
sir.
you, sir. Thank you so much, sir.